Well, hello, everybody. Darren and Lori are back here with Total
Hey
Health
there.
Pros, Ascent Elite Health. I wanted to talk to you a little bit today about the various forms of hormonal replacement. So we'll kind of start off with thyroid, just make it real easy. It's going to be a brief podcast today, but just to give you some information on types of treatment that are out there, various delivery mechanisms, those types of things, which seem to be more effective, what we've noticed anecdotally in our practice, but then also by what the new scientific research and evidence is out there too. So we'll kind of start with thyroid. So,
Yeah, I'll
Lori,
start with that one. Basically, most people, we go with oral medications, of course, with thyroid, and we can do prescription grade. We'll do like levothyroxine, which is your T4, the inactive thyroid. Then we do cytomel or liothyronine, which is the active form of the thyroid. And you also get Armour or an MP thyroid. That's just a couple of examples that are actually together in one pill.
Yeah.
It just depends on what the patient needs. Now, that being said, we also can have that compounded, and we do have to do that sometimes because some patients you try to play around that with those doses and you can't get them right, so you have to have it compounded with T4 and T3 just to get that exact dose for that patient. And we do provide that as well. But like I said, usually levothyroxine, Synthroid, those are T4s.
And those are synthetic.
Yeah, the synthetic.
So they are synthetic. It's just T4. It's probably the most commonly prescribed type of thyroid medication out there. Unfortunately, probably one of the most ineffective in regards to
Correct.
when you look at actual therapeutic outcomes, because the fact that so many patients have liver issues. And with just dosing T4, that T4 has to go into the liver, be methylated, be converted into T3. So if you have any kind of liver function issues, any problems with that conversion, you're going to get T4 and you're going to get very little of the T3, which is the active hormone. So we consistently see patients coming into our office and they're on thyroid medication. They've been on it for a long time, but they've got every thyroid symptom under the sun. And they're saying, I just don't understand why I don't feel any better. I've been on this thyroid medication forever. One, they haven't been back and had labs. Their doctor hasn't had labs follow up consistently. And then the other part of it too is they're not actually checking the conversion of T4 to T3. And so
That's
we do
very
see that a
common,
good
very
bit
common.
too. And then the other thing that Lori was talking about too with the compounded, that is a bioidentical
Correct.
replacement aspect of it. So when we do compounded, it is actual based on human thyroid hormone. Okay, so it is bioidentical. There is a little bit more effective. It's a little more expensive. Insurance typically doesn't cover it, but it is an option. The other thing about the bioidentical hormone replacement for the thyroid is it's got about a 30-day shelf life.
That is correct.
So-
And even with some of that has to be refrigerated after several days.
Yes.
So if you're going on a trip, you have to plan ahead for that and keep a cooler with you where you can actually take it on the plane. A 7-day vacation is okay, but anything more lengthy than that, you have to plan on refrigerating that or getting it in a cool situation.
So there are some complications with the bioidentical hormone replacement for thyroid specifically, but that is something to think about. We have patients coming in the office that are always wanting to be the most natural as possible. Then what Lori mentioned also too, if the other options are MP thyroid and Armour thyroid, and those medications are almost identical in structure. They basically have the same dosing. There's just different dosing that's appropriate for each medication or slightly different. But as far as the actual medication of T4 and T3 within those is pretty much the same. The one difference for the Armour thyroid and MP thyroid is it does contain, like Lori had said, both the T4 and the T3.
And it's a set dose.
And it's a set dose,
And
yes.
that's where we have a problem.
And sometimes we can run into an issue where we need patients on a different dosage than what's actually applicable in those set dosage and that split ratios of T4 and T3. Now, that is the nice thing about it is, Synthroid or the levothyroxine is a synthetic form. The Armour and MP is a natural form. Where does it come from? So believe it or not, it's actually sourced from pig thyroid gland that is food grade. So when they slaughter these pigs for market to sell their meat for your barbecue that you're eating, on Saturdays and Sundays and for bacon and everything else, these are food grade, commercial food grade animals. And so they're actually harvesting the thyroid gland, taking those thyroid glands, drying them out, what's called desiccated thyroid. So they're drying those out in specific portions and putting that into a medication. So it is very natural. It's not synthetic. The body does, for most people, process it probably better than the Synthroid. But we do see some patients that that respond better on the Synthroid for whatever reason. It's just like there is no end all be all with any medication.
That's true. Sometimes I'll get that patient that needs both T4 and T3, and I'll try them on the levothyroxine and put them on cytomel or liothyronine. And then, okay, let's switch that. Let's put you on Armor.
To make
And
it convenient.
Convenient for you, one pill, one prescription. I can change that person. And some people have fatigue. Same thing if you flip back the other way.
Yeah.
They'll have like fatigue, symptoms that just don't match up, or it just does not work as well as the other. So it like everything's independent for each patient. So we have to dose that accordingly and monitor the symptoms, monitor how well they're doing with labs. And unlike most physicians and endocrinologists, we monitor that a little closer because we want to see you
Not a little closer. We monitor a lot closer.
Exactly.
Don't be. We monitor it a lot closer. And yeah, definitely about
because
that.
we want to see. It does take a little more time for that T4
Yes.
level to convert and get at a good level, But we do not wait 8, 12 weeks, 3 months. We do not wait that long. We do things usually. If I put a T3 supplement on, 2 to 3 weeks, I'm checking that one because that should be already up and running.
And sometimes less.
Yeah,
sometimes less. And that's the big thing. So, what we do is we believe in operating in a realm that's best for the patient. So, when you come into us, we're not going to say, oh, you can only have Synthroid, or you can only have NP, or you can only have Armor Thyroid, or you can only do bioidentical hormone. We're going to see you as a patient, as an individual. We're going to sit down and discuss with you what we think was probably the best protocol type of treatment for you. But at the same time, as a patient, we want your input too. Absolutely. And so, that is a big difference in our practice than probably 99% of the other practices out there that treat thyroid. One, they don't know anything else other than Synthroid, right? And they refuse to do anything other than Synthroid just because they just don't have the knowledge base for it. And then the other part of it is the other ones just don't want to take the time to have to mess and learn with the different dosing and the things that we do, as that we do so much of an individualized practice, individualized medicine with you. And so there is a big difference in that. So, that, and really most functional practices are that way. And the fact that they don't have a set prescribed thing that they're going to prescribe for the patient, a dead on protocol every time that if you have a thyroid issue, this is what you get, right? So most functional practices are set up that way, but unfortunately just, 90% of the allopathic traditional medical practices out there, even the endocrinology practice, you're going to go in, you're going to get one drug. And if you don't want that drug, they're not going to see you, right? They will almost refuse to prescribe anything else.
And the thing that I'm seeing too, and we're in West Virginia, of course, that's our home base office, but we have such a hard time getting in, a patient has a hard time getting in to see an endocrinologist. And then a lot of the times they'll go see them and they'll say, well, everything looks good. And it doesn't look good.
No,
they're not
functionally it's
below.
not.
And I came from allopathic medicine. Trust me, I understand. And I was taught, don't muddy the water, only get STH level and a free T4 level. That's all you need. That is not all you need. I've come to find that with myself. I'm on Armor Thyroid because I found my thyroid. I look like I was perfect on paper, and I am not. So, it's just, we are functional medicine, like you said. I had a patient come to me yesterday that left a functional medicine practice online, spending tons of money every month. They just were dragging their feet with their plan, dragging out time so they would spend more money. I said, that's not how we work. You get in here the first time around, we're trying to attack everything immediately.
Yes.
That we can get taken care of and see how you feel and tweak things. That's your whole thing. You've been complaining for 2 or 3 years to someone on how you feel. Why do you want to wait another 6 or 8 months to try to even feel a little bit better when no one's attacking things immediately? So
so there is a big difference. I mean, that's one of the definite differences in a functional medicine practice, and again, just traditional medical practice. And the fact that it is very individualized. We're going to go by your metrics. We go into much greater blood work when we look at things, and then we're going to prescribe and treat off of that blood work. By no prescribed, specific protocol, we're going to do what's best for you as a patient. So that's kind of the thyroid rundown, really, the options that are out there as far as treatment protocols, different delivery methods, those types of things. So kind of the next one, we'll talk about some women's hormones in regards to probably estrogen. We can look at that. So we'll talk about that for now.
We're looking at the same situation. When I first started with Darren with functional medicine, I was looking just mostly to the more holistic, more natural side of the page. Bioidentical hormone replacement, like we talked previously about the thyroid, the same situation there. You have more natural things, plant-based things are used there as well. And I'm on that currently. People do quite well with that, but then there are some people that just want a prescription. So we've kind of as we say, it's your plan of care. And I've sat
Absolutely.
and we can start with an estradiol patch, which is a prescription, synthetic, it's made in the pharmacy. And we can go that route with your medications. I can give you a sub-Q injection of testosterone, which we'll get to later. But estrogen itself, I can give you in a patch, in a cream, in a vaginal suppository. from the pharmacy.
Oral tablet
Oral tablet.
works very well as well.
And yeah, and I usually stay away from that one because I feel like it's safer to go transdermal with anyone who's like toward menopause age. And then when you go over to the other side, you're doing the bioidentical cream. So that's, again, not typically paid for by insurance. You pay for it by yourself. But, you know, you make that choice. And I literally lie that out on a page. Okay, I can go this way. Or we can go this way. This is your plan of care. I'm not going to dictate to you which way you should be treated. But these are your options. You choose. And, you know, a patient feels really important. They feel like they're taking responsibility and they're going to be more inclined to stay with the program.
They're more involved in their own care.
And their care, and they're going to choose that plan that they want. If that doesn't work, we can always flip the coin and go the other way. And we're always in that situation where we're going to change it up, whatever works for you. So that estrogen, that's kind of how it is. And we kind of explained the...
Yeah, and estrogen is one of those ones really, I mean, again, what Lori had said too, if you go with the bioidentical, you're going to have to pay out of pocket. Not a massive difference, but when you look over, you know, a 10-year period, if you're on bioidentical hormonal replacement, you're going to be spending a good bit more than if it's running through your insurance and they're covering it fully. Right. The one thing that we also see with bioidentical is it takes longer to have your levels get to a functional threshold. And sometimes that's almost double, you know, because it is a much slower process. It's transdermal. Your body has to absorb it, as opposed to the typical, you know, prescription patch or oral tablet that you take. A lot of times you're going to see results with those in a matter of 10 days, 2 weeks, you know, and sometimes a bioidentical with estrogen takes, you know, sometimes 6 to 8 weeks. So it's a more gradual, it's definitely more natural for sure. But at the same time, if you feel terrible, you know, you don't want to wait that, especially if you felt terrible for a long time.
Correct.
Right. And you're just literally dying to feel better. Sometimes, you know, again, that's one of those things we'll sit down and discuss with you about what the best delivery option is and really what kind of just fits your schedule best. I mean, when you get into a cream, then you're applying that every day. You know, it has to be every day.
You have to have it in a routine day, part of your day.
Yep, you've got to allow time for it to dry, those types of things. So, you know, there are some differences when you get into creams versus oral. Oral, man, just same time every day, take your pill with your vitamins, whatever, right? And so it is a little easier, a little less time consuming.
I forgot to mention the troche.
Yeah, troche is the other one, yeah.
Actually, like a little tiny little square or however they make it in shape and size. You put it between your cheek and gum.
Little gummy, yeah.
Little gummy. And it takes about 10 minutes for that to dissolve. You can have it that way as well. And I mentioned the other routes of administration. But
and the troche's bioidentical as well. And where it is oral, it does seem to, because it is oral, you do have an increased efficacy or increased rate of
that, so it does go.
So it does raise your levels a little faster. Personally, I don't know what they taste like. Haven't had one, so
it doesn't taste much.
I can't vouch for that. So you know, there's much, but that is, you know, the troche is across the board for hormones. Period. That is another option that's a viable option for a lot of patients. It seems like most of our patients either go with the cream or the oral.
Correct.
Oral tablet, you know, and they want to run it through their insurance is the main reason. Again, patches work. Anytime you run into, when you're doing transdermal though, you can run into some absorption issues, particularly with other hormones. But, you know, it's one of those things, it's another variant. And, you know, when you have a transdermal patch or transdermal cream, it's just another variant in physiology, another variant in, you know, personal hygiene, those types of things that can affect how that is absorbed. Yeah.
Look at that, the actual area you put it. A lot of times they'll recommend you put it on the lower abdomen, inner thighs. A lot of women, that's where you have adipose tissue. So I myself have changed my route of administration to like my inner forearm and below my clavicle here. That plus adding another pro-hormone, which we're not going to really talk about today, but that in itself has raised my estrogen level to above 100 now. And I've been working on this diligently to try to get it up because I was suffering from plantar fasciitis and I wanted to get rid of it, and it's gone now because my estrogen is up. But that's what we just have to play with that. If you put, you know, we don't even use some of the products like progesterone. We don't even use it in a cream because it goes right to that site and you don't.
Yeah, a fatty area. It is very lipophilic. It likes the fat cells. It goes into the fat cells and you just don't get it. And there's a lot of practitioners out there that do progesterone creams. And unfortunately, if you're a patient paying for that, you're not getting the benefit at all that you should be. You know, that's one of those things you really need to do. Progesterone needs to be done orally on the side for the female hormones. Progesterone, it's much more effective. It helps a lot faster. You see a bigger difference, you know, a lot more quickly. So, you know, progesterone is one of those ones we just don't recommend doing transdermally. You know, the other ones, again, unfortunately, the more body fat you have, it is going to slow down and decrease absorption and utilization, period, right? Fat cells like to grab onto things, especially when you get into transdermal creams, and so you're not getting as much into the bloodstream. And so, that is something to think about. If you're a patient that's a little, has a little less body fat, definitely it's something that's probably going to work a little bit better for you. Again, trying to put on those areas that, some patients even put up on their chest area, where, with a little bit of a decreased body fat in that area. So that is one option that's there. But progesterone is one of those ones, again, for the female hormone side of it, really oral is a much, much better route for administration for that. And then when we look at testosterone, then we've got another, whole nother gamut there. It's kind of like estradiol, estriol, and estrone, the three different female estrogen hormones, right? But testosterone is one of those ones really for women. Again, you've got a troche that you can use. There's really no real good oral administration that we found. There's some medication out there.
Testosterone and it together, and I use that forever. And when we checked my hormones initially, when we got together as a company, I mean, I had absolutely zero level, and I was at the top dose.
And the problem with it too is it's bound with estrogen, and so if you have a patient you don't want to give estrogen to,
there you go.
It throws that application or that administration out, because if you don't want to do estrogen, the testosterone's bound to the estrogen. You can't separate them out, so you're getting estrogen and testosterone. But that medication's Estratest. It is something out there. It's something that you need to consider, but just something we've not found to be very efficacious really much at all. So we don't use it a whole lot. Pretty much as a practice, we pretty much stick with the bioidentical hormone replacement, the creams and the troches. For women, it seems that they do really pretty well for testosterone.
I really feel more comfortable. I think that that's the best route. You're bypassing the liver instead of taking an oral tablet. And that's the safest for women that are, like I said, older. I mentioned that earlier with menopause, people that have coronary disease or high risk of coronary disease, those types of things. It's better to go with the transdermal route. And we usually start with as low as we can go, and increase and see how the patient tolerates. And just to throw this in here, when we have someone who has high risk for coronary disease, or they have elevated cholesterol. Now, your cholesterol or bad cholesterol can elevate when your estrogen is low. That happens. It's just
a lot. We see all the time with patients in perimenopause, menopause. Correct. Estrogen levels go down, LDL levels go up.
It happens to everyone. So when that happens, we definitely say, well, listen, just go down and get a coronary calcium screening for $75 out of your pocket. Yeah. If you feel better about that, then it's clear. Then we know we can go ahead and just proceed quicker with the therapy. Otherwise, we are very cautious. And those that have had estradiol or estrogen-related breast tumors or breast cancer, I have a client who's 5 years post-procedure. She's been on an estrogen blocker, was on that for 5 years, currently off of that, no recurrence, and she is now allowed to have low-dose estrogen transdermal cream because she's in menopause and she's having symptoms. So these are there. You don't have to rule these out anymore if you have had these.
New science really shows there's not much correlation between your estrogen level and breast cancer risk. There's just that's what the studies, meta-analysis, when they go back and look thousands and thousands of patients that have been treated via estrogen and monitored levels and seeing what their breast cancer, they're pretty much finding it's not any more than the normal population. Actually, sometimes it's less with patients on estrogen.
And the benefit way outweighs the risks.
Estrogen is a highly, just really strong anti-inflammatory. Lori had already mentioned it. She just said it. She was suffering from plantar fasciitis, and we see that all the time. So if you're a perimenopause age, menopausal age, and you've started to notice, hey, I'm getting plantar fasciitis, it's not responding. A lot of times it's the low estrogen. It's that quick drop in estrogen, the anti-inflammatory part of that you lose, and estrogen has a massive musculoskeletal component. So that's one of those things. If you're in perimenopause in that age bracket, menopausal age bracket, and you're starting to see those issues and those signs, those symptoms, then definitely, and you're starting to see some musculoskeletal complaints, it could very likely be the level of estrogen. You go on estrogen, it literally can fix those in a matter of a couple of weeks, and your pain is gone. Like, it's a massive difference.
I want to mention here that everyone just signifies menopause with hot flashes.
Yeah.
That happens generally after a lot of these other things have happened.
It's kind of the last thing.
Tinnitus, dizzy spells,
hair loss,
musculoskeletal, brain fog, your memory's kind of just foggy all the time. All these small symptoms that are just classified as, you're just getting older. These are all usually relative to your estrogen levels.
Yes.
And, they're just finding more and more. And these are not noticeable. You complain about that and they go, everybody's dizzy. Or it's just your medication you're on. It's just kind of thrown off. And, I'm just going to mention here, if you go to your provider and you're saying, I'm thinking my hormones are off, I think can we check my hormones and see where I am? If they deny you that right as a patient, find somebody who'll do it.
Yes.
Because these are issues
They're
that
not
get
looking out
addressed
for your best
early
interest
on
at that
in
point.
your life.
Right.
Your life needs to be, we need to be feeling, I'm 60, I want to feel like I'm 30 all the time. I might not look it,
Well,
but I
we
want
have
to feel
patients
it.
in menopause at 45 now.
Exactly.
I mean, that's young. You got a lot of life left ahead of you to be miserable if you
Absolutely.
don't get that addressed and taken care of, right? And so that's the big difference. So, find a provider that will listen to you, that will listen to your complaints, listen to what's going on, and then we'll actually try to figure out what's going on or get you referred to an
Absolutely.
office like ours. Absolutely. So, progesterone, low progesterone can be a weight loss issue. You can see that your inability to lose weight as a female can be simply because of progesterone dropping. Also, progesterone is a massive issue with sleep. So if you're a female and you're in that perimenopause, menopausal age and you can't sleep, a lot of times that's a progesterone problem. So, again, that's something to look out specifically for progesterone issues.
And progesterone also is a carrier into the cells of estrogen. So
Yep.
to get that in, that's what helps. We talk about testosterone causing belly fat on men, and it can happen on women as well. But this estrogen is the same thing. If you don't get that into the cells, estrogen into the cells, you can have an increased weight of your waist. So
especially if you have a
progesterone
high
is a
carbohydrate
carrier.
diet,
Yeah.
insulin issues, which is a whole nother discussion. But
Absolutely.
because we're just really talking about delivery systems and what we've seen work best in our practice. And then in regards to testosterone, then like we said, the troche you've got. Oral's not really an option because of the estra test, being bound to estrogen.
Mm-hmm.
And, some patients it works, we just haven't seen good results with it. But then the other option for females is using an insulin needle, a 29 gauge insulin needle, and giving yourself a shot once a week, which a lot of women like the fact that it's a once a week thing, right? And so it's easy. They don't care about the shot. It's an insulin needle. You don't even feel it, literally a 29 gauge insulin needle. It's a once a week deal. It's not a daily application. Your levels do go up a little quicker with the injection of that. There's really no disadvantage to it other than the fact of you just have to give yourself a shot once a week. When you look at overall level of cost, usually your insurance will cover it. And so, that's something to consider, but that is another option in regards for women with low testosterone. And it seems like we're having more women as we give them that choice to actually choosing that. Yeah. And so, that is one thing. And we are seeing maybe a little bit better results with that even.
Yes, and I'll say that you could possibly, as we do with men with intramuscular injections with their testosterone, if you have to have a higher level of testosterone to get you where you need to get, you can do that like twice a week as well. You can do it multiple times a week subcutaneously. Men can do it that way, but typically they do the IM.
Yes.
And if they're on a high dose, they'll go with the twice a week injection.
Yeah.
Also with testosterone with men, we use the cream as well.
Yep.
We have several gentlemen that
We
actually
have a lot, probably about 50% of our patient population on
They are
testosterone
actually doing well.
take the creams. Yeah, use the creams.
I have one gentleman just saw 2 days ago that we changed him to gel. The cream, I think the gel may dissolve a little bit more, go into the cells a little bit easier. We've just switched him up because he's kind of dropped a little bit on his level. But that the pharmacist, I had a consult with a compound pharmacist. She said, let's go with a gel instead. But still, that's a topical situation. And you get that done every day.
Yeah. And it seems like a lot of our guys, we have some guys now that have chosen the troche to use, and they do extremely well. Their levels come up pretty quick. And so we've seen some, variations in that, but definitely it's one of those things that, the alternative methods of delivery, the creams, the gels, the troche for men definitely are they work. We haven't seen a whole lot of differentiation in results as far as getting testosterone levels to where we want them to be. But again, the creams and the gels take longer. Just across the board. It doesn't matter what you're doing, whether it's estrogen, progesterone, if you're doing testosterone, the creams and the gels take longer to get threshold levels and to get your levels up. They still get you where you want to be. It just takes longer. So, that is something to consider. We do discuss that with our patients. Injections always, speed up the process. It's always quicker with the injections. But, that is something to consider if it's a timeline for you, cost for you, depending on, whether your insurance covers it, out of pocket, those types of things.
A lot of the women, too, when I tell them that, it's going to take, we need to tweak this, we can start low. They go, I like that idea. Because they've heard for 20 years that hormone therapy is terrible for you, and you have cancer, and they're scared of it. So,
which is understandable.
All the evidence is out there, and the new meta-analysis that's covered every study known to man on estrogen,
literally
out there,
yes.
It just came out in March, proclaims the better benefit as opposed to risk. They feel more comfortable to say, that's good, that's great. Let's start low and move up slow where I can see how I feel, and if it's improving, then once they get used to it, give me a higher dose. I'm feeling a little better. My clarity's a little bit better, but I know I can be better than that. So it's nice to see that they are taking responsibility and being accountable for their own care. and their plan works. We work with them before that.
Now, the other thing too, that there's some new medications out that Lori and I we haven't had a chance really to use them much because it's just one of those things we really haven't had a chance to look at as far as efficacy and the studies out there. But there's a new medicine called Kysotrex, which is an oral testosterone for men only. It's high dosage. It's not applicable for women at all. And then Jatenzo is another one that's another oral medication for men that's just out. I don't know that there's a lot of studies on it yet as far as efficacy and how it's used. I haven't ran into a guy that's been on it yet, that's come into our practice that's been on it. And so it's one of those things that, it's out there. It is an option. So it's something that, if you come into an office, discuss that with your provider, absolutely discuss it with us. It's one of those things we're looking at as far as incorporating into our practice now. It is a lot higher dosage. It does do a good job from what I've read in regards to quickly increasing men's testosterone levels. Again, oral, the only thing with oral with testosterone, you do have a little bit more of an increased effect on the liver. So it can, harm the liver and its function a little bit. So it's one of those things that, periodically you've got to check liver enzymes, those types of things. Can have a negative impact on your HDLs and LDLs a little bit more so than some of the other ones because it is an oral and it doesn't bypass the first round of liver metabolism. But again, it's a good option, right? And so a lot of people out there, this could benefit. Again, they're new medications. So it's something to be, if you're thinking about testosterone therapy, it's something to research.
And we also know that new medications are very pricey.
Yes, always.
And you're not going to want to cover it. So it's probably going to take a little more time for that to actually be used more freely, but we're definitely looking into that for anyone who would be interested. But again, when a new medication comes out, it is absolutely off the chain.
Usually through the roof. Yeah, through the roof till they go to generic or it just they get increased usage. Sometimes they'll drop the price. Sometimes they increase the price. It's just really hard to tell. I haven't had a chance to look to see what the pricing is on those. That's going to be one of those ones. If it's something you're interested in, call your pharmacy and find out. And if your insurance even covers it.
Correct.
Because I can tell you, if it's $200 or $300 a month, your insurance is going to go, no, you can take a shot for $25.
That's right.
For $25 a month, not $25 each shot, $25 a month. We're not going to pay $300 or $400 for a new oral medication for testosterone, even though it might be more appropriate, even though there might be, a better fit for you, whatever. They're just not going to want to cover it. So but then who knows? Maybe GoodRx. A little plug for GoodRx.
So we actually use GoodRx a lot. I mean, a lot of times we have to battle the insurance company when it comes to testosterone levels because men can have a low testosterone at 300, and that looks like it's normal on the normal scale. But that's the lowest number of normal. So insurance does not want to pay for your testosterone unless you've been below 300 2 or 3 times. Now,
right.
Let's take that person who's making that judgment call, give them a testosterone of 300 as a gentleman, and see how well they feel. They're not going to feel good. They're not going to have any recovery from exercise. They're going to be fatigued. They're not going to have any libido. They're not going to care about anything in life. Their whole zest for life's not going to be there.
Right.
But they're not the people they're making decisions and they don't feel like you feel. So we basically use GoodRx. I'm a prescriber. I prescribe your testosterone. I monitor your levels. We monitor your levels all the time to make sure we're doing it safely. You go pay cash typically at CVS, where Walgreens is $27 to $45 for 4 vials of testosterone.
Well, we've even seen it's crazy because the prices will fluctuate. There was one point it was like $12 for a 1 ml vial. It was nuts, and it doesn't really matter if it's a 1 ml vial or 4 1 ml vials. It was $12 for the month of treatment. And I don't know how that operates, how that works, but that's one of those things you can always check on those prices. It's really easy to really Single Care is another one, but it seems like GoodRx is what we've seen with the most coverage. So, pretty much straightforward there on delivery routes for you guys. So, Lori, you have anything else to throw in on it?
No, but we're functional medicine, and insurance doesn't like to regard what we do. They don't want to pay us for visits,
right.
So we charge cash. So any way we can help anyone with prescriptions like with GoodRx use
and save money, yes, absolutely.
We have an Access lab that we use. It's actually discounted labs for people who have a high
deductible
on their insurance. We try to do everything we can to make it more cost effective for your care. So don't let that steer you away from coming to see us because we're a cash-based or health savings account card payment. Or, we do that, but everything else that we do is either going to be sent to your lab for your insurance purposes to be paid for, or we can use some type of an access that we have to help you with the cost. So, we'll work with you with your plan of care, just like we mentioned earlier. That is all in and entails your plan of care.
Don't devalue your health either. I mean, that's the thing. It's the one thing that you can absolutely control. I've made this joke before. I've never known anybody, if I said, hey, listen, I'm going to give you $1 million, but you're going to die in 15 days, Or, I can not give you $1 million and guarantee you're going to live another 35, 40 years, be very happy and healthy. I don't know anybody's going to say, yeah, I'll take the $1 million and die in 15 days, right? Because people do inherently value their health. I mean, they don't want to overtly say that, and it's not something on the top of their mind. But, health is extremely important. There's just so many things that you can miss out in life because you don't have the energy, you don't feel good, you lost muscle structure or those types of things. So, don't take any of that for granted. And again, your health is probably the most important aspect of your life because you just can't do what you've been put on this earth to do without it, right? You can't be a good mom, you can't be a good dad, you can't be a good brother, husband, whatever it is, right? So you value your health. Put your dollars where they can make the most impact.
Yeah.
100%.
Spend it on your health. And you're going to be around for a while.
Cut the Starbucks out here and there. So
I won't even pay for Starbucks. I won't pay for it.
Not that I'm knocking on Starbucks.
But I'll buy supplements to help me stay young.
We'll spend lots of money on supplements. But you guys, so thanks for your time and watching our podcast. And, we're getting more and more downloads every week. We truly appreciate it. You can find us on Facebook at Ascent Elite Health, on Instagram, Total Health Pros. Our podcast is out there under Total Health Pros. So 304-382-2080 is our office number in Hurricane, West Virginia. Our website is totalhealthpros.com. I didn't screw that up this time, man. I put that right out there nice and easy. So guys, if you've got questions about your health, get a hold of us, email us, message us through our website, whatever. But we're here to help you. Again, we treat every patient as an individual. And so when you come in our door, that's what you're going to be treated like. You're going to be treated like family. We love what we do. Lori and I both say every day, there's never a day that we feel like we get up and have to go to work. It's just something we love doing. It's both inherent for both of us. We just love what we do. It's a gift for both of us. So we really appreciate you guys. Thank you so much. God bless. And we will see you next week.
God bless you. Thanks. Bye.
Appreciate it.